Today I'll be discussing the rationale for the use of toceranib in treating mast cell tumours in dogs, and I'll be evaluating research to determine its efficacy. Firstly, I'll refresh our minds on what mast cells are. Mast cells are derived from pluripotent hematopoietic stem cells of bone marrow and are found in most organs in the body. They are most abundant in organs that are in direct contact with the environment, such as skin, lungs, and the GI tract. Mast cells contain granules, which contain substances such as proteases, cytokines, and histamines, which results in them playing an integral role in inflammatory and immune responses. In dogs, mast cells are known for their neoplastic transformation, especially in the skin, with cutaneous mast cell tumours accounting for up to 21% of all canine skin tumours. They can occur in the liver or spleen, but this is less common than skin. These tumours are generally single masses that vary in size and shape. Their etiology is unknown, but is thought to be multifactorial. The risk of developing a tumour increases with age, and also some breeds are predisposed. Paraneoplastic signs such as erythema and wheal formation are common in dogs with mast cell tumours due to the release of granule substances from mast cells. Mutations in c-KIT, a receptor tyrosine kinase, have been found to be involved in 20 to 30% of canine mast cell tumours. These mutations result in unregulated tyrosine kinase activity and cell proliferation. Based on this information, the oral drug toceranib, a tyrosine kinase inhibitor, was created. Toceranib competitively inhibits ATP at its binding site on these tyrosine kinase receptors, VEGFR, PDGFR, and KIT. The binding of the drug at these receptors inhibits receptor phosphorylation, ceasing mast cell proliferation and blood supply to the mass. Toceranib is commonly used to treat non-resectable grade 2 and 3 cutaneous mast cell tumours in canines, but is not approved in use in cats. Side effects are generally mild and most commonly are seen with diarrhea, anorexia, lethargy, vomiting, and weakness. In 2003, a dose-escalating trial of toceranib was conducted on 57 dogs with a range of tumours that had not responded to standard treatment. The study found that mast cell tumours that had KIT mutations had the highest response rate, with 40% responding to the drug. However, this study may have had misclassification bias due to tumour assessment being conducted by different investigators. Similar results were observed in 2009 in a randomised blinded clinical trial. In this study, 153 dogs with grade 2 and 3 mast cell tumours were randomly assigned to a toceranib or a placebo. After this blinded phase, those that responded had open-label treatment of toceranib. During the blinded phase, 37.2% of the dogs being treated with toceranib responded, compared to only 7.9% in the placebo group. In the open-label phase, the overall response rate of the dogs to toceranib was 42.8%. The study, like the previous, found that mast cells with a c-KIT mutation had a high response rate. It was also interestingly discovered that mast cell tumours with mutations were not associated with a worse prognosis. This study was conducted well with a large cohort size and significant p-values. To avoid bias and ensure consistency, all the histopathology was assessed by one pathologist. Although being found to be an effective drug against mast cell tumours in canines, resistance to toceranib has been known to develop in long-term treatment. However, there are still drugs that are effective against mast cell tumours that show no resistance, including lomustine and vinblastine. Further studies will be needed to overcome resistance in toceranib and to find more effective drugs against mast cell